you don't know me, my name's Shannon. I'm one of the PGY3s here in the Department of Emergency Medicine. I'm talking today about sepsis, specifically risk stratification of patients with sepsis in the emergency department. Now, this is a multidisciplinary talk. It involves experts from the Department of Emergency Medicine, so we're happy to have some of our faculty here from the DEM, as well as some of our staff intensivists are here, because truly doing this on a global level is going to require buy-in from both departments. I very quickly just want to make a distinction that's going to come up a couple times in the talk, okay? There's a difference between a screening test and a risk stratification test, okay? A screening test identifies people who might have a disease from a population, say those who present to the emergency department. A risk stratification test then takes those patients that the screening test has discovered and then classifies them based on their degree of risk for reaching some type of outcome. But that's an important distinction that I need to let you guys know off the bat before we go any further. So as I mentioned, today we're talking about sepsis. And the word sepsis, unfortunately, this is a bit of a disclaimer, is a little bit of a loaded term these days. It means different things to different people, and this definition is changing. The reason is there is no gold standard for sepsis. If you have a patient in the emergency department who has a fever, is tachycardic and hypotensive, requiring pressors, who's intubated with an acute kidney injury, most of us would look at that patient and say, that patient has sepsis. Most of us. We wouldn't be 100% right because there's no blood test, there's no imaging test, there's no pathology diagnosis that will actually tell you. It's a syndrome. And so for that reason, there's a lot of disagreement. So you're not going to learn everything there is to know about sepsis today in 1 hour. My hope is you're going to learn 4 or 5 things that the next time you see a patient in the emergency department with infection, you're going to be able to apply at the bedside. So we have been studying sepsis for decades. We must know some things about it. And we do. We know a few things. So we know sepsis kills, and it kills a lot of people. So this is an old public service announcement from, I think, the late 90s, which said sepsis kills about 250,000 Americans a year. We know now that number is an underestimate. It's well over 300,000 that we attribute to this disease. But we know it kills a lot of people. We know it starts with an infection. Now, most of the time, this is going to be a bacterial infection, whether it's a UTI or a pneumonia or a skin and soft tissue infection. We know it starts with an infection, and we know it involves a very complex response from the immune system. So one of the misguided thoughts about sepsis is a lot of people think it's the infection that is what's actually causing the syndrome that you see. But it's not the infection per se, it's the way your body responds to that infection. And that's what the syndrome is. And that results in the last thing that we really know about sepsis with confidence, and that is it results in end organ dysfunction. So that's acute lung injury leading to ARDS, acute kidney injury, and various other sort of things hallmarks that we attribute to this disease. When it comes to treatment of sepsis, we know some things work, and we know other things don't work. So this is a really nice slide from BMJ this year, which really summarizes the things that we know have benefit and the things that we don't think have benefit. So Manny Rivers in 2001 was actually onto something. With his early goal-directed therapy. We know now that the therapy doesn't need to be goal-directed, but the early part, the early fluids, the early antibiotics, the early administration of vasopressors, that is what improves mortality. What I'm hoping to convince you today is that emergency physicians really need to own sepsis. And they need to own it from the perspective of detection and risk stratification and early management. That is really the job of the emergency physician, and that's what I'm hoping to convince you of today. And the reason is because 78% of people who end up in the ICU with a diagnosis of sepsis or septic shock come through the emergency department. They either go directly from the emerge to the ICU, or they go to the floor, deteriorate on the floor, and then ultimately go to the ICU. But 78% of these people are going to see an emergency physician first. I probably don't have to convince you that if you send somebody home with undiagnosed sepsis, they are not going to do well. They're at high risk of mortality or a poor outcome. But what gets less press is that if you send somebody to the floor, and they deteriorate, their outcome is worse than if you sent them directly to the ICU. So therefore, the important part here is identifying these patients early, identifying them before they deteriorate. And that's really the crux of the problem. So what we do in the emerge every day is we pick out the sick people from the not so sick people. So how do we do that, and how do we do that effectively? When it comes to the Ottawa Hospital, this is how we do it, and this is how we've done it for the last few years. So this is our triage sepsis that you see at triage that the nurses use. So it utilizes the SIRS criteria here, as well as factors that they associate with increased risk of mortality from sepsis. And these patients are triaged accordingly. And if you're the emergency physician and you pick up a chart, you're going to see this, which is our protocol, where you get the blood work that you want is automatically ordered, and you get to choose your antibiotics based on what you think the supposed source is. So we've done that for several years, and recent work from Dr. Tamara McCall has shown that this actually has mortality benefit. So a 13.4% mortality reduction after implementation of this protocol. So this study got a lot of press, but we know that this sort of intervention improves mortality. Patients do better. And I don't think anyone who's ever utilized one of these sepsis bundles ever disputes that. But the question is, how do we get the right people? Are the people who are included in this bundle that get this, are these the right people? I took this picture in recess at the Civic one day that I was working, and you can see there's 4 patients in recess, and 3 of the 4 of them have the target sepsis. Now, do all 3 of these patients have sepsis? Maybe, but we don't know. What I can tell you is the patient I'm seeing in bed 7, I'm seeing from ICU, and that's a patient in forward septic shock who doesn't have the target sepsis, who wasn't triaged appropriately. So are we missing people is the other question. All of this boils down to the fact that disposition matters. And I don't really need to tell you that because that's what we do every day in the emergency department. We need to accurately predict who needs to go to the ICU right away, who can be maintained on the floor, and who, if anyone, can go home. And that's what this talk is about today. So this talk is divided into 4 parts. The first part, and probably the lengthiest part, is we're going to talk about sepsis 3, the new consensus definitions of sepsis. This is something that a lot of people identified as something they wanted to know more about, and it has important implications in the emergency department. We're going to talk about lactate, because lactate is now something that we get really early on in resuscitation, and that's something that can help us guide our treatment. We're going to very quickly review some clinical decision rules that have been utilized for sepsis, and we're lastly going to, in a self-serving way, talk about some new evidence that we've been working on to answer this question of risk stratification. I'm hoping at the end we'll have some time for discussion, but if there's anything that requires more clarity that you're not sure about, please chime in and I'll try my best to clarify for you. So we'll start talking about detection. And basically, to know where we're going, and when you talk about sepsis 3, you need to know what we've tried before and what has been done. And the fact that there's a sepsis 3 implies that there was a sepsis 1 and a sepsis 2. And they happened in 92 and 2001. And for our purposes, I'm just going to pool them together because they both say the same thing, really. They both define sepsis on the basis of the SIRS criteria. And that's something that we all use today and something that we're very comfortable with. And this slide I took from my second-year medical school lecture on sepsis. This is how I, as a med student, learned about sepsis, that it was a continuum from SIRS with infection to severe sepsis, which is organ dysfunction, and then ultimately septic shock, which is the onset of hypotension. And that's how a lot of people still think of it. But there are problems with thinking of it in this way. So first, and as most of you know, the SIRS criteria are not very specific. So you see them in a lot of things that have nothing to do with infection. And that's one of the problems. So you see it, and I've listed some of those diseases there. What a lot of evidence seems to show is that about 18% of patients who present to the emergency department have some variation of the SIRS criteria. And of those patients, about only a quarter of them actually have infection. So you can see the SIRS criteria envelops a large proportion of patients that we don't think of as having sepsis, but are included with that using that tool. A lot of people will look at that and say, who cares? Who really cares if it's specific? Don't you want it to be sensitive? And I actually had this discussion with one of our attending internal medicine staff recently when we were discussing this, and she said, I don't understand why everyone cares that SIRS is not specific. Your job in the emergency department is not to miss anyone. You can't send these people home. So if you catch some people who are falsely positive, is that really a big deal? I agree with that to some extent, but there are some issues. So in medicine, and generally, you want to treat the people who have the disease and avoid treating the people who don't. And I think that's a general principle that we all practice with. And what I hope that I don't have to convince you is the treatments in sepsis are not benign. So if you have somebody there who's got an EF of 25%, and you're about to put 4 liters or 3 liters of fluid into them, that's going to have an effect. The antibiotics we're using are not small antibiotics. We're using piptazo, vancomycin, meropenem. These are large, big gun antibiotics. And the worst thing that we're doing to these patients is we're admitting them to hospital. So I made this point yesterday at Journal Club. If you look at any RCT that's been done, and you look at from any venue, and you look at if that looks at mortality, there's always going to be a segment of patients who die just from being in hospital, who die from nosocomial infections, who die from iatrogenic events. So admitting people to hospital, which is what we typically do with these patients, can have effects. And for the emergency physician specifically, I would argue that there's always a competing interest. So I showed you this image earlier, which I took randomly on a day in recess. What might look even more familiar to you is this part. So these patients get admitted to services, but they don't leave the emergency department. They stay in the emergency department. They affect our throughput, they affect our quality measures, they affect patients in the waiting room who are waiting for these monitored beds. So there's a price of oversensitivity. So the question a lot of people ask you, though, is how sensitive are the SIRS criteria actually in identifying patients with sepsis? And the study that tried to answer this was from Kokkonen and colleagues last year. So this was a pretty big study. It got a ton of press, and it really changed the way a lot of people thought about the SIRS criteria. So this study was done, a retrospective study of over 1 million people that they took from Australia and New Zealand. And what the investigators did here was they started backwards. They said, let's take the people in the ICU that we know have sepsis or we think have sepsis and septic shock, and let's see what their SIRS criteria were. What they found was that 1 out of every 8 patients with those severe degree of illness had 0 or 1 of the SIRS criteria. So what they're suggesting is the SIRS criteria actually technically misses 1/8 of these really sick patients. What they then did was they looked at the group that had 0 to 1 SIRS criteria and the group that had 2 or more. And they wanted to see was there any difference in mortality. And they found that there wasn't. So basically, the cutoff that we've always used for the SIRS criteria seemed to be arbitrary. So for a lot of people, that was the final nail in the coffin of SIRS. They were like, this is not a good tool. It misses a lot of people who have severe illness, and there's no difference between having immortality if you have a SIRS greater than 2 or less than 2. So that led us to where we are today, which is Sepsis 3. And for those who don't know, Sepsis 3 was a series of 3 papers published in JAMA earlier this year. I'm going to discuss each of them really briefly, just so you understand what the take-home messages were from each of them. So the first paper was the overview paper, and it was done by this gentleman, Dr. Murph Singer, and his co-chair, Dr. Cliff Deutschman. Now, what they did was they put together 19 experts who they thought were the people that, a task force of people that they thought could, who knew the pathobiology of this disease and could define it. What you'll probably notice, or you may not, or most of you probably know, is of these 19 people who were involved, there were 0 emergency physicians. So this led to a lot of controversy because, as we all know, we see these patients all the time. We're on the front lines in detecting and risk stratifying these patients. So Murph Singer was recently on Scott Weingard's podcast, MCRIT, and Scott asked him about why there were no emergency physicians involved. And his response, I thought, was very poignant. So I'll just play it for you guys.
Why were no emergency medicine folks at the table when these were being discussed?
Yeah, and we put our hands in the air, owned up, and say, "Yep, we screwed up."
And that's it. They screwed up. So they recognized that they should have involved emergency physicians, but by the time they had defined this, the definition that they had come up with was not very emerge-centric, and that's something you're going to see. So the take-home points from their study are as follows. First, they removed SIRS from the definition of sepsis, and the reasons are the reasons I pointed out before. The Kokkonen study had a huge impact on that. Second, they said there's really only 2 things that we can say with certainty about sepsis. Number 1, it starts with an infection. We know that. And number 2, it results in end organ dysfunction. So if these are the only 2 things that we really know with certainty, the definition should reflect these 2 things. Then they said we need a unifying language. And that I actually do agree with. Because if you look at the studies of sepsis, the people define it differently depending on the study you look at. So some people will call sepsis 2 or more of the SIRS criteria plus infection. Some people will call it positive blood cultures, which we know culture-negative sepsis exists and is a significant proportion of patients. Some people will just use what was the diagnosis that the physician wrote at the end. So that has led to huge discrepancies in the epidemiology of this disease. So we do need a unifying language. So they said there's 2 components now to Sepsis 3. And they were very specific about this. First, they said we need a definition. And they're like, a definition is what something is. So if you open the dictionary and you look up sepsis, there should be 2 to 3 sentences that describe what it is. And then second, we need clinical criteria. So that if you're a clinician and you're seeing a patient, you'll be able to diagnose them based on these clinical criteria. So they separated those 2 things. The definition they came up with was this. Sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. Now, there are a lot of problems with this definition. What do you call life-threatening? How do you define organ dysfunction? What's a dysregulated host response? What's a regulated host response? So they didn't actually address these in the paper, and I think that's one of the shortcomings of this definition. Then they said, let's come up with clinical criteria to diagnose a patient with sepsis on the basis of that definition we just created. And for that, they used the SOFA score. And the SOFA score is actually an old score. It's from 1998. And they used it for two reasons. First, it has really good evidence that backs up that it can predict mortality in ICU patients. Very good evidence. And the second thing is the SOFA score uses organ dysfunction as its major points. So that was something that they knew was associated with sepsis, and that's why they felt comfortable using it. So now, if you want to diagnose someone with sepsis, you need two things. You need suspected or documented infection, which hasn't changed, but instead of the SIRS criteria, you now need an acute increase in the SOFA score by 2 or more within 48 hours after the onset of infection, whenever the onset of infection is. So if any of you have ever seen the SOFA score, it is not an easy thing to calculate. It involves a lot of things that I would argue we never measure in the emergency department. So a PF ratio, I've never measured one in the emergency department. We don't always get bilirubin. We don't always measure urine output over the course of a day. And we don't use these as our first-line vasopressors. So for us in the emergency department, this probably doesn't have a lot of utility. But the authors actually recognized that. They said, you know what, using this in the emergency department doesn't make a lot of sense. We need something that they can apply that's not as time-consuming or cumbersome. And that's where QSOFA came from, okay? And I'm sure a lot of you have heard of QSOFA, but we'll talk about it really briefly. This was the second of the 3 papers. And this was work done by Dr. Chris Seymour. And what he said, and some of you might actually recognize him because he's actually done a lot of pre-hospital sepsis research. His goal is to have paramedics be able to diagnose sepsis in the field. What he said was, if I'm at the bedside of a patient in the emergency department, and all I know is that patient has an infection, what are 2 or 3 things that I can use to determine if that patient can have an outcome, or a bad outcome, without the use of labs or any PF ratios or anything like that, just 2 or 3 things. So what he did was a retrospective study. And he actually included 1.3 million people initially, from which he defined a pool of 150,000 that he said had suspected infection. And these were patients in the emergency department, in the ICU, on the floor. And the way he defined suspected infection, because it was retrospective, was he said if the clinician ordered cultures or antibiotics. So we know that's an inherent problem, but because he couldn't ask these clinicians prospectively, that's how he had to do it. And so he divided it into a derivation and a validation. And you can see most of these patients are outside the ICU. In fact, most of them are from the emergency department. And when he did that, he came up with 3 criteria that routinely predicted if a patient had a bad outcome. And those 3 criteria were the QSOFA. So a bad outcome in this case is the patient dies or they go to the ICU. So the QSOFA are these 3 criteria. They are systolic blood pressure less than 100, which can be a problem because we know some people walk around with a blood pressure less than 100. Altered mental status, which he defined as a GCS less than or equal to 13. So a lot of people ask, why did he use 13? And the reason he used 13 was he did this retrospectively. So if he saw a patient who had a GCS of 14, he didn't know if that was because of the infection or because they had baseline dementia and were just disoriented. So that's a problem, because a GCS 14, and myself, or any of you, assuming that you don't have dementia, is probably concerning in the context of infection. And the last thing is tachypnea. And what he found is if you had 2 or more of these criteria at the bedside, you don't need any labs, you are at a high risk of a bad outcome, either dying or going to the ICU. So just very quickly, how many people have either ever calculated a QSOFA score, heard of people using a QSOFA score anywhere? Has anybody used it? There's more than a few people. And I have actually seen this. I've seen these in eMERGE ROTs. I've seen them in medicine consult notes. I've seen them in ICU admission notes. People are using the QSOFA. But if you're using it, you need to know what it is. Okay? So there's a few things that you should know about it. First, and this is the least important thing, QSOFA does not define sepsis. So this is just a terminology thing. But they made it very clear in this diagram that if you have a QSOFA greater than 2, you still need to calculate the SOFA score before you can call someone sepsis. That's just a nomenclature thing. What's way more important that you realize is that QSOFA is not a screening tool. It's a risk stratification tool. And then what I mean by that is it is designed to maximize specificity and not sensitivity. Again, it is not a screening tool. It is a risk stratifier. So if it's there, that's bad. That patient's at high risk. But if it's not there, you should not be reassured by it. It has very poor sensitivity. And that's depicted in this diagram. So you can see a small proportion of the patients with infection actually have a positive QSOFA, but they make up a large proportion of the deaths. However, there's a group of people, how large we don't know, who don't have QSOFA more than 2, who die. So that's an important thing to realize. And the last thing that you should know about it is it's never been prospectively tested in the emergency department or anywhere. It was derived retrospectively, and all the studies that have been published thus far have been retrospective applications of it. No one has ever used it prospectively. I just very briefly want to talk about septic shock. This was the third of the 3 papers. And all I want to say about septic shock is the reason that they went ahead and defined it was this was a subgroup of patients that were at increased mortality. So mortality in this group was about 40%. And the 2 things that you needed to call someone septic shock were vasopressors to maintain a MAP greater than 65 and a lactate greater than 2 after adequate fluid resuscitation, whatever that is. So if you have those 2 things, your likelihood of mortality is 40%. And that's really all I wanted to say about it. So many people have probably heard that there's been a lot of resistance to sepsis 3, a lot of controversy around it. And for their part, the Surviving Sepsis campaign, which has been our major source of treatment recommendations, has basically said implications of new definitions, ignore them, basically. You should continue as essentially has been previously recommended by the Society, or by the Surviving Sepsis campaign. So that's where Sepsis 3 comes in, and that's how Sepsis 3 fits in to the Surviving Sepsis campaign. So the take-home message, therefore, is as follows. These are the points I want you to take home from Sepsis 3. Sepsis 3 has removed the SIRS from the diagnosis of sepsis. So that's important. We'll talk about that a little bit later. To now diagnose someone with sepsis, you need presence of infection with an increase in the SOFA score by 2 or more. The Q-SOFA score, as I mentioned, can be used at the bedside, but remember that it is not a screening test. If it's negative, it should not reassure you. But if it's positive, it's high specificity for a poor outcome. And the last thing is septic shock is defined now as initiation of pressors and a lactate greater than 2 after adequate fluid resuscitation. So those are the major take-home points of Sepsis 3. We're going to shift gears a little bit and talk about lactate. So lactate is now something that is probably among the first blood tests you get back when you're resuscitating a patient. And a lot of us use it every day. And one of the important things is when you get a lactate, we often associate that with shock. But one of the first things to realize is that there are types of shock. Your lactate can be elevated for reasons not related to shock. So if you have an elevated lactate and it doesn't seem to make sense, you should think of type B lactic acidosis. So DK is the poster child for that people often cite, but it is one of those things that you should think about. But if you're an emergency physician and you're treating somebody with infection and you get a lactate, there are really only 2 questions that you need to know the answer to apply that lactate appropriately. The first is there a critical lactate level above which the patient is at increased risk of a poor outcome? The second question you need to know the answer to is if I draw a second lactate and it's going down, it's clearing, does that indicate that the patient has a better prognosis? Does it indicate that I'm resuscitating this patient well? That's the other question that you need to know the answer to. So we're going to look at these 2 questions specifically. First, there is actually evidence that the initial lactate level that you draw has prognostic information for you about that patient with infection. So this was work done by Dr. Nathan Shapiro, who's probably one of the best-known emergency physicians who studies sepsis. He actually wrote the sepsis chapter in Rosen's. And what he did was a prospective study where he enrolled about 1,300 patients, and he drew a lactate on everybody who showed up. He followed the patients who were admitted to hospital, and he looked at their 28-day mortality. What he found was that the initial lactate level that was drawn had a good prognostic indication of whether that patient was at increased risk of mortality. So a lactate level specifically over 4, he found was not very sensitive, but was 92% specific for a poor outcome. And you'll see a lot of people actually cite this lactate level of 4. Scott Weingart does it all the time. And if you listen to his interview with Merv Singer, he mentions it multiple times. He's like, what if somebody's Q-SOFA negative, but they have a lactate above 4? He's like, should I be worried about that patient since it's not in Q-SOFA? And this is just one of the figures from the study which shows that increased mortality when you get above 4. So lactate, again, has a poor sensitivity. It's a poor screening tool like Q-SOFA. But when it's above 4, that has high sensitivity or high specificity for deterioration. And for their part, as I mentioned, Sepsis 3 has included this in their definition of septic shock, that you have to have a lactate above 2 after you get fluids. When it comes to lactate clearance, there's more controversy. The first attempt at actually looking at lactate clearance was done by Dr. Brian Nguyen and some guy named Rivers in 2004. So what they did was another prospective database study where they took 111 patients and measured their lactate when they arrived in the emergency department and then 6 hours later. They included sicker patients, so patients with hypotension or septic shock, as per the old definition, and again looked at 28-day mortality. What they found is that the patients who lived past 28 days had significantly higher 6-hour lactate clearance than the group that didn't. So there did seem to be some sort of indication from that early lactate. But it didn't really answer the question of how much is a good amount of clearance and after how long. The study that tried to answer this was by Dr. Ryan Arnold from New Jersey, and he did the same study, essentially. So he took 166 patients with septic shock and measured their lactate when they arrived and 6 hours later. But what he did was he stratified his patients into patients who had a lactate clearance greater than 10% in the first 6 hours, or those less than 10% at the first 6 hours. And again, he looked at 60-day mortality. These are the Kaplan-Meier curves, and you can see that the patients that cleared that 10% in 6 hours had increased likelihood of survival as compared to the group that cleared less than 10% in 6 hours. And for their part, again, the Surviving Sepsis campaign recommends that you target resuscitation to normalize lactate in patients with elevated lactate levels. So the take-home message is, from lactate, is that your serum lactate that you initially draw, that you get in the emergency department, can tell you a lot about how this patient's going to do in terms of specificity. So again, a lactate greater than 4 is where the evidence is what most of the evidence has supported as this critical lactate level, mostly associated with poor outcome. Lactate clearance does seem to provide some indication of effective resuscitation. People who look at these studies say, well, they measured it at 6 hours. When do we ever measure another lactate at 6 hours in the emergency department? And the truth is, you probably won't. But if you measure another lactate in 2 hours and it's gone down by 40%, that should reassure you maybe a little bit that your patient's moving in the right direction. And always remember that this is all clouded by the fact that lactate levels are not always completely a function of tissue hypoxia. So that's what I wanted to mention about lactate. And I'm just going to switch gears again a little bit. So in the emergency department, I think a lot of us realize that it's hard to really risk stratify these patients and identify who's going to do poorly and who's going to do well. And what we always fall back on are clinical decision rules. They help us decide who to image, who to treat, where to disposition patients. And you'd think, after like 30 years of sepsis research, that there's probably been a couple of clinical decision rules that have been derived for use in the emergency department. And there is. There's been actually over 12. But very few have stood the test of time in terms of how well they've done in validation. We're going to talk about 2 scores today because I think they're the 2 best ones, and I think they're the 2 that have the most evidence behind them. The first is the SOFA score, which, as I mentioned earlier, has been incorporated in Sepsis 3. And the second is the MED score. So the SOFA score, as I mentioned, was derived in an ICU population and is exceedingly complex. So I don't have to mention this again, but as you can see, a very difficult thing for us to calculate in the emergency department. And because of that, very few people have tried to apply the SOFA score in the emergency department. The one study that really tried to do this was by Dr. Jeff Klein, who many of you know from MRAP. And what he did was he had a prospective database of patients with infection. And so he said, let's apply the SOFA score and see how well it did in this database that we have. So he included patients over 17 with ICU admission, so again, sicker patients. And he measured SOFA scores when they arrived in the emergency department and 72 hours later in the ICU. And the main outcome, again, was in-hospital mortality. And what he found was that the SOFA score at 72 hours in the ICU was actually quite a good predictor of mortality. But the time 0 in the emergency department was not as strong. So this is just their ROC curve. We talked about this yesterday at Journal Club, but basically what you're looking at is in an ROC curve is a measure of accuracy. So the increased area under the curve of the ROC will tell you how accurate your tool is. So you can see the SOFA score at 72 hours in the ICU had an area under the curve of 0.84. We said anything over 0.8 we usually just say is quite good. But at time 0 in the emergency department, it's 0.75, which isn't bad. It does show some application, but not as strong as it is in the ICU. So the take-home message on the SOFA score is that it might have great predictive power in the ICU, but we're not sure actually its utility in the emergency department. A lot of you will probably look at that and say, it doesn't really matter to me because this was derived in the ICU and tested in the ICU, and all of its power has been demonstrated in the ICU, that there must have been an ED-specific tool that's been devised. And there was. This tool is called the MED score, the Mortality in Emergency Department Sepsis. Quick show of hands, who has ever heard of this rule before? Okay. There are a couple people who have heard of this rule, but very few people know that it exists or apply it in the emergency department. So this is, again, work done by Nathan Shapiro. And what he did was a prospective observational cohort of all patients in the emergency department where cultures were ordered. So he recognized that in the emergency department, our population is lower risk. If you look at patients with sepsis in the ICU, their mortality is upwards of 30%, 25 to 30%. The mortality of patients with sepsis in the emergency department is about 6 or 7%. So we have a lower risk population in the ED. So that's why he wanted to include any patient that an ED physician ordered cultures. And I think that's reasonable because you're probably ordering cultures if you're concerned about infection. He looked at 29 different variables from history and physical, vital signs, and lab values. He did not include lactate. And he didn't include lactate because at the time, it wasn't something that was routinely measured. And he looked at 28-day mortality. What he found was his area under the curve for derivation was 0.82, and for validation was 0.78. So it actually seemed to be a good rule. And this is actually what the rule is. So you can see it includes some things about the patient, so whether they're from a nursing home or their age, or whether they have a terminal illness, though I'm not sure if you'll always know their prognosis about whether it's less than 30 days. It includes some lab values, platelets, and then it includes some physical findings, so tachypnea, septic shock, altered mental status. And he's assigned point values to each of these. And if you're ever having a patient with infection, you can actually plug it in to ED calculator and calculate their med score. And it'll give you a risk of 28-day mortality, which in this patient's case is 9.3%. So you can apply it. Unfortunately, the reason it hasn't been used a lot is that it has some problems. In validation studies, it hasn't stood the test, really. Area under the curves of like 5 different validation studies have had an area under the curve of as low as 0.6 and as high as 0.77. It hasn't never broken the 0.8 in a validation study. It does not incorporate lactate, which we know does have some benefit in terms of prognosis. And it's not really well known or well used. And a lot of people argue that because of the absence of lactate, it's a little bit outdated. And so while you may be able to apply it in the emergency department more easily, it's not really clear whether this is something that we're going to be using far into the future. So the last part of the talk, as I mentioned, is a little bit self-serving. I hope at this point I've convinced you that this is really difficult. If you see a patient at the bedside who has infection, it's really, really tough to know if that patient's going to need the ICU or if they're going to be able to go home. Those are really difficult things to do. And that's because this is a really complex disease. And we've been trying to apply very simple tools to understand it. And that's where the disconnect is. This is actually mentioned by Dr. Seeley in a recent editorial he wrote in Critical Care Medicine, which for me was really disheartening because I actually started working with him because I wanted to get better at predictive modeling. And then he just wrote a paper saying that it was really difficult. But it really highlights the problems with predicting not necessarily whether a patient's going to die, but are they going to deteriorate if you send them home? Are they going to get worse? Several of you might recognize this gentleman. This is Jacques Farkas. He runs PalmCrit, which is an offshoot of MCrit. And he recently reviewed a study that looked at QSOFA retrospectively and showed that QSOFA didn't work very well. I read through the article and I read the comments, and he wrote something really specific that I thought really hit the nail on the head of what I've always thought about risk stratifying patients with sepsis. He wrote this. He wrote, eventually I think we will probably have a very sophisticated risk stratification tool that's built into the EMR that will extract all sorts of data from the patient's charts, so their labs, their vitals, and continually filter it through a complicated mathematical formula to perform continuous risk stratification. And until we have a complex tool like that, we're going to have to rely on more simple tools. This is exactly what I've thought, that realistically we're trying to apply a simple tool to a complex dynamic disease, and it's not going to work that well unless we can look at it over a period of time. And so that's what we've been trying to do here with heart rate variability. So heart rate variability is exactly what it sounds like. It's the beat-to-beat variation in your heart rate. And Dr. Seeley has been studying this for 16 years. He told me, corrected me. But this is my attempt to summarize 16 years of research in one slide. So heart rate variability is a real-time biomarker obtained from the ECG recordings. Okay? It reflects autonomic modulation and cardiopulmonary fitness. So all of us have heart rate variability, beat to beat, but it's not obviously recognizable unless you actually look at it on a microscopic level. What we find is that there's decreased complexity and decreased HRV when you have increased stress or illness or with increased age. So HRV will change in these settings. We measure using multiple different measures, but for our purposes, it's been shown to be associated with presence and severity of sepsis. It's been shown in trauma. It's recently been shown in ACS. For anybody who remembers Marcus Ong, who did his clinical epidemiology here, he's actually applying HRV right now to ACS. to see if he can predict the diagnosis and the prognosis of patients who have ACS. And it has value in the emergency department because it's immediate and you get it at the bedside. So the only attempt really to apply this in the emergency department was done by Dr. Doug Barnaby, who's in New York. He's one of our collaborators. And what he did was he took a small populations of patients with sepsis and applied one measure of HRV and was able to predict with 100% accuracy who was going to live and who was going to die. So we know now that that's not the case. It's not that simple, that we replicated the study and it didn't work out quite as well. There is a signal, but it's not as strong. But what we're trying to do is put together a puzzle with 1,000 pieces to try and understand this disease, of which heart rate variability might be a few pieces, it might be many pieces. But the more pieces we have, the better picture we're going to get of how to prognosticate with this disease. And that's what led to this study. So this is the Sepsis and Variability in the Emergency Department study, or the SAVE study. So this is a collaborative study between the emergency department at Albert Einstein College of Medicine in Bronx, New York, which is Doug Barnaby and Dr. John Gallagher, as well as our lab, so myself, Dr. Andrew Seeley, and Dr. Christoph Harry here at the University of Ottawa. So the SAVE study has a very specific aim. It's an emergency department-centric study, okay? All of the studies that you've seen before were derived in the ICU and tried to apply to patients in the emergency department, except for the med score. This is a unique study in that we're looking at ED patients specifically with possible sepsis. And all of the studies I've shown you before have looked at mortality, usually at 28 days or 60 days. So Doug's an emergency doctor, and he always says to me, he says, I don't care if I see somebody in the emergency department and then they die on day 28. It doesn't really have a lot of implication for me. I care if I send somebody home with infection and they deteriorate, they come back in 72 hours and they need to get intubated or they need to go to the ICU. He's like, that's what I really care about. It's way more emerge-centric. So we wanted to look not at mortality specifically, but deterioration, and I'll define that, in 72 hours. So this was a prospective observational cohort study that was conducted at the ED at Montefiore Medical Center in the Bronx. And this is sort of the way I've gotten around ethics at the University of Ottawa. I just do studies now at other hospitals. So they gathered data for 24 hours a day, 7 days a week, for several months, from 2014 to 2015. The inclusion criteria that we involved in the study is very important. So we included adult patients who met the diagnosis of sepsis on the basis of the SIRS criteria and suspicion of infection. And the way that they were enrolled in this study was they had to be enrolled by the emergency physician. We didn't look back and see who ordered cultures or who ordered antibiotics. The emergency physician had to enroll the patient, meaning that if you suspected the patient had infection, you enrolled them. And the way we did it, the way this was done, was it was linked to the sepsis protocol. So much in the way that Dr. Perry, if you want to send somebody to TIA clinic, you got to fill out his form. This was kind of the same thing using the sepsis protocol. So these patients were suspected and treated for possible sepsis. We excluded patients that met the endpoint within an hour, because as Dr. Venk will tell you, if someone reaches your outcome within an hour, you probably don't need a clinical decision rule to help you determine that. If somebody comes into the emerge and their blood pressure is 60 on 30, and you give them 2 liters of fluid and it goes to 70 on 40, and you start pressors, I don't think you need a rule to tell you where that patient's going. So we excluded those patients. We excluded patients that had DNR status, and we unfortunately had to exclude patients who had non-sinus rhythm, and that was because HRV doesn't work as well when applied to this population. So HRV was done for 15 minutes when these patients came, and we looked at deterioration at 72 hours. And the way we defined deterioration was as a composite outcome. So if you met any of these things, you were considered to have deteriorated. Either you needed intubation, you needed CPAP or BiPAP for more than an hour, and we excluded OSA patients or OHS patients from this because they might need it anyway, so they couldn't meet that outcome. Whether you needed vasopressors or inotropes for more than 24 hours, or you got admitted to the ICU for more than 24 hours, or you died. I think if you're seeing a patient at the bedside with infection, these are the things you're trying to predict if they're going to need. Because if they're going to get worse and need these things, then you don't want to send them home, or you don't want to send them to the floor necessarily. So we ultimately ended up recruiting 1,174 patients, of which 89 met the deterioration outcome within 72 hours. And we derived 5 different models for prediction. Just very quickly, these models, one model used only lab values to see if we could predict deterioration using only lab values. One used clinical values alone, so these are vital signs, essentially. One used HRV alone. And then one combined lab and clinical values. So that's usually what our typical prediction rules are now. They're a combination of lab values and clinical values. And the last one added HRV to this. And just very quickly, these are the areas under the curve. So you can see the area under the curve of the composite with lab, clinical, and HRV had an area under the curve of 0.84, which was an improvement over just lab and clinical values alone. So what we found was that this model actually did seem to predict deterioration quite well. So if you look at the variables that were involved, the 8 variables that the machine predicted had the best predictive value, they make sense. So 3 of these were HRV variables. 3 of them were clinical variables, so rest rate, heart rate, and systolic blood pressure. So those are things that we commonly look at when we're trying to determine if somebody with infection is sick. And the last 2 are lab values, which are lactate and creatinine. And again, these are 2 of the most important lab tests that we look at in trying to prognosticate for these patients. If you divide the group into sex tests based on their score, you'll see the group that had the 1/6 of the group that had the highest score had an increased risk of about 3.7 times. So as I said, about 7% of patients met the outcome. So that means if you were in the top 1/6 of your score, you had about a 25 to 28% chance of deterioration. Whereas the bottom 2/3 had about a 2 to 3% chance of deterioration. So using this model, you can actually predict 5/6 of your population with pretty good accuracy. The last thing we wanted to do is, since we had this database, we wanted to apply QSOFA to it. Because as I mentioned to you before, no one has ever prospectively tested QSOFA on a group of emergency department patients, or any patients for that matter. So we looked at in-hospital mortality or ICU admission for these patients, which is the outcome that they had used. And we had all their QSOFA scores gathered prospectively. And so this was exciting. It was the first prospective application of QSOFA, and it did not do well. So when we looked at the predictive power of QSOFA in our group, it had generated a sensitivity of 22.5%. So that means of the patients who died or went to the ICU, 22.5% had a positive QSOFA. The rest did not, had a QSOFA of less than 2. Specificity was high, it was 95%. That led to a positive likelihood ratio of 4.3 and a completely useless negative likelihood ratio of 0.9. So this actually fits with what they had said before. The QSOFA is not a screening test. It misses a large proportion of people that have that outcome, but it's highly specific. It's a risk stratification. So if you see it, that patient is at increased risk of meeting the outcome. So the take-home message then from the SAVE study is proper sepsis risk stratification is multifactorial. I think we all know that. It's a complex disease. We need to apply a complex tool to it. The outcome that you look at matters. Every tool that I showed you before has looked at mortality at 28 days. But you have to determine what's more important to you. And I would argue that as an emergency physician, you should care more about what happens in the next 24 to 72 hours when you're making a decision on disposition. So we've derived a model that shows an added benefit of all of these things. And then lastly, QSOFA did not do well in our population. So again, it can risk stratify, but it cannot screen. So at the beginning of the talk, I said I hope that you would gain 4 or 5 things that you could apply at the bedside the next time you see a patient with infection. And these are the things I hope you've gained. First of all, I want to suggest that we keep using SIRS to identify and screen. And this is an opinion, but it's an opinion that at least has some evidence behind it. We don't have a better tool. There's nothing better that I can recommend to you to actively screen patients for whether or not they have infection. And for that reason, the tool that we have used has been shown to have really great mortality benefit. So there's nothing evidence-based for us to change from that at this point. SOFA, as I mentioned, is probably not ideal in the emergency department because it involves a lot of things that we don't routinely calculate. If you're going to apply QSOFA, though, do it properly. Know that it's not a screening test. Know that it works as a risk stratification tool at best. I kind of find it funny because, for me, QSOFA is really only valuable if you see a patient in the emergency department who's hypotensive, tachypnic, and altered, and you weren't sure that patient was at risk of death or ICU admission. And that's really, honestly, the truth about how well it is incorporated. Keep an eye on your lactate. I mentioned the lactate level of 4 or more has really good specificity and it's evidence-based for detecting mortality. But always think of other causes of elevated lactate. If your lactate doesn't make sense, think of type B lactic acidosis. And the last thing is, proper risk stratification, as I've said multiple times, is multifactorial. It involves a lot of things. Patient factors, it involves blood work and lab markers, it involves clinical markers as well. And that's something that we should always remember. I think when we look beyond and where we're going in the future, there are a couple of things that I think have to be our priority as we try and further identify this disease. I hope I've convinced you that mathematical modeling really does have great power in determining how these patients are going to do. My hope is that we still validate the tool that we've derived, and I hope we do it multi-center. And I hope we can get more patients so that we can derive a tool with the best accuracy. Because ultimately, I do see sepsis as being something that risk stratification happens continuously. Maybe it gets built into an EMR where you get a value that tells you, not a range that they're low, medium, or high risk, but when you pick up a chart and you see that their initial likelihood of deterioration is 30%, and by the time you're assessing them, it's 65%, that tells you something about the trajectory of that patient. And I think that's something that's really valuable. I still think we need a good screening tool. So for now, I've suggested that SIRS is what we have to use, and that's because that's where the best evidence is. Are we going to get something better than SIRS? Maybe. We might. But I don't think we're going to get too far from it. But I think that's still something that we need to work on because we do really care about sensitivity. We do really care about not missing patients with the disease. And lastly, this is going to continue to be an issue. These patients get admitted, but they stay in our department. They don't go. They affect our throughput, and they affect our quality measures. So what I'm hoping is using the database that we have, now that we've predicted what makes people do poorly and deteriorate, let's look and predict what makes people do well. The people who went home that didn't deteriorate, what were the factors that led them to do well? Now, these may be the same factors that lead people to deteriorate, but we don't know until we test it. That's what I hope to do. I want to end with a quote from Cliff Deutschman. He is the other co-investigator on Sepsis 3. He's one of our collaborators. And he was also recently interviewed by Scott Weingart. And he said in closing something that I thought was really profound that I just wanted to play for you guys because I think it says it a lot better than I could.
The most important thing I would say moving forward is keep testing this stuff. Look at everything, duplicate what we've done, but do it prospectively. If you've got a database, apply the things that Chris did to that database and see if it holds up. Look at different patient populations. It's up to all of us to keep this thing moving forward so that it doesn't stall for 15 years again. I would be very disappointed if within the next 5 years we didn't change everything all over again. I think that's essential to improving the care of patients. I think it's essential to getting a handle on the biology of this really bad disorder.
And I agree with Cliff. I would be very disappointed if in a few years we hadn't changed everything, we hadn't moved away. And my hope is that when we do this again, that emergency physicians will be at the table, that they'll lend their opinion, they'll lend their expertise, because we are the people on the front lines of this disease, and we have important input. And ultimately, that's what's going to lead to the best outcome from our patients so that we get further in understanding, in research, and in treatment of sepsis. So there are a lot of people who were involved in this talk, a lot of people I ran things by, a lot of people who listened to me give it. I just quickly want to thank Dr. Seeley and Dr. Kasilowitz, who went over the slides with me in great detail multiple times, and I know made this a significantly better talk. So thank you all for your attention. At this point,